thank you for that introduction. I've been really pleased that transition's come up already today. It's something that I think is really important for us to talk about. And it's one of my special interests really. I'm a paediatric surgery registrar. I'm training to be a consultant. But for the last year I've held a NICE scholarship. NICE, you may have heard of, it's the National Institute for Health and Care Excellence. And it's their job to promote best and excellent practice through guidelines, through assessing and praising drugs and technology, and through sharing learning. And so I've been doing a selection of projects over that year with NICE, some of them locally in my hospital, and some of them more national. I'll talk about those as we go. So what is transition? Lots of you will have a good idea already. It's basically moving children and young people through adolescence into adulthood, negotiating with their condition. And on the screen you can see the Department of Health definition, which is actually really helpful. It's a bit wordy, but it's very helpful. And there are some things to pick out. Transition is not just a single point in time. It's a process that can take many years. And lots of the evidence that's coming out at the moment is that starting to think about becoming an adult needs to start early on, maybe 12 or 13 years old. I remember meeting a young girl in clinic who was 21, which is in a children's clinic, her and her mum and a paediatric surgeon. And she was told for the first time when she was 21, sorry, you can't come to the children's hospital anymore, that's it, there's nothing more for you. And sadly that may well have been the experience for some of you as well. And there were tears in clinic. The girl, the mum, the surgeon, everyone was in tears because that's really distressing. And actually good transition can stop that happening. The other thing is the kind of multidisciplinary approach to transition, which we've mentioned earlier on. Transition should address social factors, emotional factors, schooling, education, work, because all of those can be impacted by a medical condition. And part of transition is learning to be an adult with your condition, learning who to go to if there's a problem, how do I get an emergency appointment, what do I do if I need a repeat prescription, all of those things that your parents do when you're little, but when you're an adult you have to learn to do for yourself. And we want to avoid that feeling of a little goldfish in a really big pond. There will be changes in the adult world, it's inevitable, but what we want to do is help young people to navigate that and get through that. So there are a number of different models of transition care, and we touched on a few of them a bit this morning. One of the common ones you see on the screen, you get seen by a children's specialist when you're a child and an adult specialist when you're an adult. And if you've got esophageal atresia, that may be surgeons, maybe respiratory physicians, and there may be other specialists involved as well. But the key to this is the bit in the middle of the two circles, this crossover period that might include joint clinics with all of those people sitting down in the same room together to address some of these ongoing issues. And that means that the young person in the family will have met an adult surgeon before they've had to leave children's clinic, so it's a bit more free-flowing. And as with anything, including specialist nurses, dietitians, and the GP in this process is really important. Another way of doing transition is having your paediatric surgeon forever, which does happen in some places. And that's great because you get the person who's known you and your family for your whole life, and you don't have to keep explaining your story to new people. One of the drawbacks of this is that us as paediatric surgeons don't know very much about adult conditions, in the same way that adult surgeons don't know so much about children's conditions. So that might be something that we need to ask help for if we follow this kind of protocol. And the third way of doing it is less common, and it's having it all coordinated by a general practitioner that knows you and the family and the community. This happens less often for children, but as you're an adult it might be more appropriate if you're needing specialist help less often, if there are years in between what you need. This could work well. So we all know that getting getting the right support through transition through adolescence is going to feel good, isn't it? It's going to help with emotional support, it's going to help with social support. That's easy to understand. And I think it's important to think about how a good transition can have an impact on medical care as well. And I'm going to look at a couple of examples from other specialties just to show how important good transition is. So the first is people with kidney transplants. So there's been a study of young people with kidney transplants, and that found that 35% of young people with kidney transplants had a loss of their transplant. It stopped working within 3 years of moving on to an adult team. And that's not the kind of thing that happens for adults or for younger children. So there's something special about adolescents that needs special looking after. It could have been because of poor compliance with medicines, not coming to appointments, not following the right dietary advice and things for kidney transplants. But there's something that needed sorting out for those transplant groups. And in young people with diabetes as well, there's actually quite a good transition programme for young people with diabetes that's national. And they found that young people who are enrolled in a specific transition programme have lower blood sugar, and they reduced the admissions with diabetic emergencies by a third just by a good transition programme, which is really significant. And the other thing for us as paediatric doctors is that if we know what happens to you as you're growing through young people and in adults, we find out what happens when you're 30 and 40, and that helps us look after the new children that we get to know better if we've got those long-term results. So it helps us by keeping you in the loop. So I wanted to know what the transition situation in the UK was. So I did a national survey of paediatric surgeons, and this is general transition, not just esophageal atresia, but I asked them about all the things that they look after. And I asked, do you have a specific transition programme or clinic or pathway in the place where you work? And this graph's a bit sad. Only 26% had a specific transition pathway, and lots didn't. And then the next thing I asked was, do you have any funding? Do you have any money available or resources to do a transition clinic? And that was a yes. And this highlights one of the problems that we have with transition. There isn't very much money around, there aren't very many resources, and there are very few people with a special interest who are really going to push these changes through. Another difficulty we have in paediatric surgery is that we look after rare conditions, and it is difficult to find adult surgeons, adult doctors, adult dietitians who understand all of the ins and outs of things like esophageal atresia. But we need to work together to do better. In Nottingham, I've recently set up a colorectal transition clinic. We have joint clinics between a paediatric surgeon and an adult surgeon and the specialist nurses. And what we've found after running those clinics and working together is that we've learned a lot from the adult surgeon, the way he does things, the way he approaches things, and he's learned a lot from us. And so that working together is something that we need to keep doing more. I've recently met with an adult surgeon in Nottingham who's willing to take part and look after some patients with esophageal atresia, so that's coming for this group as well. Transition is on the national agenda now. It's something that over the last 5 years or so people have started to talk about more, because we've recognised that we're looking after children with rare conditions better, so we need to look after them as adults as well. So NICE, that I spoke about earlier, have put out transition guidelines. They came out in February this year, and they're actually really helpful. They're very general, they span healthcare and social care and some education, but they have some really good principles for what we should be doing in terms of transition, how we should provide that kind of care, And what I hope is that having black and white guidelines will help those people who hold the budgets, who make funding decisions, who are commissioning services, will see that transition is important and needs to be done. So watch this space. So we've talked about some general transition points, we've talked about some specifics, but I thought I'd just mention a couple of things specific to esophageal atresia in adolescence and adulthood that might be something we need to think about. The first one is esophageal stricture. This has been talked about a little bit earlier on, and that's where there's a joint in the esophagus, it can get narrow and cause dysphagia, it can cause food bolus obstruction. And this can happen any time, it can happen to children, it can happen to adults way down the line. And so it's something that young people need to be aware of as they're growing into adulthood. There's a study in Finland done a number of years ago, had 101 adult patients with esophageal atresia, and they found that 8% in their group had a stricture at some time. One of the ways to treat an esophageal stricture is a balloon dilatation, so we've got some x-rays on the screen. The first picture you can see is some dye going down a narrow esophagus. The middle picture is a balloon stretching it up, and the third picture is a slightly wider esophagus. When you're a child, you can have your esophageal dilatation under a general anaesthetic, so it's easy and comfortable. You get play specialists and Where's Wally books and lots of fun things. But when you get to being an adult, this kind of procedure is often done in an endoscopy unit, sometimes with sedation, sometimes without anything. And actually that change can be a difficult thing for young people to deal with, and can cause real problems with the help that they need. So this is something that we could talk about at transition type clinics. The other thing to mention is cancer risk in esophageal atresia. Actually, there are lots of unknowns with this. We don't have all the answers yet, but there is work being done to look at some national data to work out if there are people getting cancer or not. At the minute, we think the risk is quite low. But there are a significant number of people who have Barrett's esophagus when we looked at on endoscopy. Barrett's esophagus is a change in the lining of the esophagus that can be precancerous, and so does need surveillance endoscopies and checkups. What's interesting is further follow-up studies have found no cancers in that group with Barrett's esophagus. And if you look through the medical literature, there are only 8 cases in the world of cancer in the esophagus in people with esophageal atresia. So the risk is low, but it's something that we need to be aware of as we're moving through that transition time. So, at the minute, we've heard already that transition services for esophageal atresia across the UK, there's not much happening. In some places there might well be established services, but in lots of places there aren't. And actually, myself and a team in Nottingham and a team at UCL in London are starting a project specifically looking at transition in esophageal atresia. And we want to know what's happening already. We're in a position at the moment where we can design brand new services or drastically change old ones if they need it, in line with what is good transition and what you want. And so this study is designed to ask, what do you want? TOFS has kindly agreed to help us with this study. Graham has assured me that you are a group of people who are keen to be involved in research and are keen to improve the care for your families and for other people with esophageal atresia. And so we'd love you to be involved. This is going to be a questionnaire study, so we're going to ask you questions about your esophageal atresia and your transition experience. And we will send it to you if you agree to be contacted. Broadly, there are going to be 2 groups. The first group, aged 12 to 18 years now. The reason we picked this group is because you're the group who are coming up to that transition age, teenagers starting to think about becoming an adult. And we want to know if your doctors or nurses have started to talk about transition. Have they got a plan for you as you move through to adulthood? And actually, what do you think you'd like as you get to that point? And then the second group are the 20 to 26-year-olds. So those groups who've just been through transition, or not, if there wasn't anything. And we want to know what happened to you. Was it good? Was it bad? What would you have wanted if you could do it again? At the minute we're not doing other age groups, but that may well come later. And if you're really, really keen to be involved, then do get in touch, because I'd love to hear from you.
What about 19-year-olds?
19-year-olds, oh, you're so close.
Talk to me
at the end.
Sorry, you said 12 to 18-year-olds.
Yeah.
Before we started, I asked you a question about what happens when Prof leaves.
Yeah.
Lucy's 10, she's already been discharged by your surgical team.
Yeah.
What do we do? Because normally we go to Prof, and he's respiratory, but if we've got any surgical concerns, he rings Mr. Stewart. Prof's going. How do we get anything?
So I think as
She's already been discharged.
yeah, as Prof Ossie was saying, we love getting calls from our patients. If you need help, we're here. So ring us and say, you've not seen us for years, but we'd like to see you because and you'll struggle to find paediatric surgeons who'll say no.
It's okay to be this, but you need to get the first bit right initially.
Yeah.
Yeah, which, that's lacking already.
Yes.
The multidisciplinary approach is not everywhere.
Yeah. I agree with you.
So
This is why we're doing the work.
Yeah.
Yeah.
There's gaps already.
Yes. Yeah, we know. And what I hope is when we've got results from this kind of study, we will be able to disseminate them into journals and conferences that are for paediatric surgeons and for adult surgeons and for other disciplines, so that we can prove, we can show them what you want and what you need. Can I keep going?
Oh.
And I will come back. We've got some time for questions at the end, so I'll just keep going for the last little bit. So this is a bit of what the questionnaire looks like. It asks you some questions about esophageal atresia. What we like is for young people to fill this in with their families, so we get the kind of whole family view of what's been happening. We think it'll take less than half an hour to fill in, and we'll ask you to post it back to the TOFS office so that we can get the results. What you send back to us will all be confidential. We won't find out your names and addresses and things like that. And obviously no data that goes through to be published will be identifiable, so you can be confident in that. It's been through ethics approval, like all surgical research has, and if you want more details about that, I can give it to you. We don't want to just make services, to start services that we think will be best because we're the doctors. We want to know what you want and what you need. And so we'd really love you to engage with this project. Without you responding, we'll struggle to get useful results. If you want to start now, if you're keen to get involved, I have got some packs with me, so come talk to me at the end. You can take one away with you today. And what I hope is that we've got you thinking about transition. Go away, talk about it with your families, with your young people. And do ask your doctors and nurses and people that you see in clinic about it. If it's not been brought up already, say to them, please sir, what's going to happen when I'm 16? Because we want you to be challenging what's happening, and we want to do better. We want to provide a service that will continue to look after you well into adulthood. So let's work together to get better. It will improve. Have a cat for now. Sorry, so there were some questions. Yes.
Yeah. Although we have a repair for infants, we're not fixed. It's a lifelong condition, and we're just ignored when we're adults. I was a staff nurse and I spent 12 years getting nowhere, and my health declined as a consequence. And my other question is, as an adult, how often should we be screened for the cancer risk of Barrett's esophagus?
So that's something we don't know yet. We don't yet have the data really to say you definitely need an endoscopy every year, every 5. We don't know. But there are good protocols for adults with Barrett's esophagus as to how often they should be surveyed. So the question is there Barrett's esophagus or not in the first place? And that will be related to whether you have reflux as a big problem particularly. If you're worried about it, then you do need to be seen by a surgeon who knows what they're doing with regards to upper GI surgery really. That might mean going back to your GP. It might mean asking a local paediatric surgeon who they suggest. Even though you're an adult, you can ask the question, who do you suggest I go to?
I had trouble getting funding from the area I live in to see a specialist who was a long way away in the country, and they kept saying you've got normal anatomy, you had a repair, and so many people want to say you're fixed, you had surgery, why do you keep coming back? And it's so wrong, we're not fixed. We're joined up, but we're not fixed.
And we agree with that, and what we hope is that over time we can keep saying that. You can keep saying it with your voices as patients and families, and we'll keep saying that from the paediatric side as well to encourage adult teams to be involved.
I mean, this is sort of related to what Sam was saying. If you're looking into transition, are you going to be looking at also as a part of it, mapping where the specialists are in adults? So if you know what's happening in paediatrics, what are adults? Because, you know, for some of us, it's, you know, in my case, it's over 14 years before I got seen again. And if you don't know where to go, and it's a chance conversation with another adult talk on Facebook, sorry, that's probably dangerous. We shouldn't be in that position. Whereas if we know that there's adult services and where to go, then that makes a big difference. I'm not in Scotland, and there's no facility in Scotland.
Can I just say our surgeons, Nick Maynard in Oxford, said that tell any TOFs, adult TOFs, to come to me if they want to. So be aware of him. He's in Oxford.
That's really
Nick Maynard.
It's one of the questions we've got in the older age group questionnaire is who are you seen by, if anyone? How far would you be willing to travel? How far is acceptable? It's something that we need to do better.
But he said he's very willing to see us, he's interested in us.
And this idea of centres for rare diseases where we know who to send people to is a great one.
Russell also wanted to say something,
because I don't want people getting on this cancer stuff. This stuff is being overplayed. We're talking about probably less than 10, certainly I'm only aware of 5 cases in the literature, now we have 5 cases. And there's been a very elegant study done from, again, our colleagues in Scandinavia, from Helsinki to long-term follow-up. We talked about this last night. When you're born in Finland, you have a unique identifier. They can track you from grave to grave, and they don't see any significant long-term risk. So the issue of endoscopy, to some extent, needs to be inbuilt into a voluntary sort of partnership with an adult patient, and depending on their individual health. So, for example, somebody like you, Grim, I couldn't really drag you into hospital and say, "Do you know what, Grim, we'll put you to sleep again. I'm going to scope you, you're going to tell me you're going to become bonkers. You're perfectly healthy." So this stuff has to be tailored to the individual patient, based on their degree of esophagitis, whether they be a child, as a teenager. We now do a sign-off endoscopy at adolescence for handover. So I think it's very important to a parent group not to frighten people, and this is being overplayed, and we need to get sensible about things. We all have a lifetime risk of cancer, irrespective of what we've been born. And this is absolutely, we're talking 5 cases in the world. So let's just be a little bit more calm about how we say these things to people.
It wasn't my intention to.
No, but I think it's important to be
be
transparent about these issues.
Thank you.
You want to say another question here?
It's really good that you're doing this transition for children and young people. I think that's really good. But for myself as an adult TOF and some of the other adult TOFs that fit, you don't always actually need to see a surgeon. It's about managing a long-term condition, especially when you've got an employer and you're off work and you're exhausted and they just say, "What?" And they just don't. Trying to explain to a layperson, well, I've had this surgery, it was so long ago, and then, well, why is it impacting on you now, 30 years later? But it still does. And obviously it's less invasive, the younger ones have a keyhole, but when you've had, really invasive surgery as a baby, you still have a long-term condition. I'd really like some advice on how to manage that, especially when you've got employers, and in terms of, sort of how to explain things. And I don't necessarily need to see a surgeon, I don't particularly want surgery, I don't want to go through all that again, but it's how do I manage it? And again, it might be back to lifestyle factors, diet, environmental things, and things like the asthma and the breathing and things like the age level. Does that have, is it a wider holistic thing that could be looked at there?
Basically, the adults need MDT all the
Yeah.
lives
Yeah.
when they've got health issues, not when they're like Graham.
Yeah. So there needs to be a service there to access
Yeah.
if you need it, and pointers as you work through to where to go.
Yeah, I'm just thinking, and I'm just thinking on the hoof here. You know, not too long ago, we actually did a little leaflet from TOFS for adults. You know, we've got the GP one as well. It just makes me wonder whether we should have a little leaflet that maybe people can give to their employers, even if it's only a couple of pages. Yeah.
It's really an observation from this morning. I mean, I think we do have to acknowledge that as paediatric surgeons, the health service generally, we don't manage this condition as well as we could, right from the start to the grave. And it's, you know, it's clear this morning, for example, that a lot of places don't have multidisciplinary clinics. A lot of surgeons are quite happy to discharge TOF children quite early in life. And I think you could make a very good case for the fact that there should be basic national minimum standards of what should be expected for the care of these children. The problem is when you start trying to talk about this, you run into all sorts of political resistance. Well, to be honest, the biggest resistance will not be the government, it will be the medical profession itself.
Really?
Wanting to protect their own particular fields of practice, their own way of doing things, and just the general inertia of the health service.
That's
And actually, as a patient group, you probably have more influence in bringing about this sort of change than any doctor will do. And I mean, I would put it to you that you should decide what you would expect as a basic standard of care that all TOFs should have. And you should fight for it, because the medical profession isn't going to do this, because they're going to be too divided over their own self-interest.
Okay, that's very, very interesting. Good advice, and I'm quite interested that you said what you said, because I think we've instinctively...
Do you agree, Professor?
I think we've instinctively...
I generally agree with Mr. Jones and everything. And I think he's right. No, I think he is right. I think he is right. I think that you are the momentum to get that.
Just an extension of what you're saying, should there not be a national register of all TOFs children?
That's another thing.
Well, again, probably there should be, but you know, then you come to the question of who keeps it, who controls it, who collects the data, money, time. I mean, ultimately, you know, when you need to change things for the better, you've got to be seen to be a group who stands outside the politics, and you do stand outside the politics.
Well, that's very encouraging, actually, for us to
Politicians will
yeah.
listen to you.
Yeah.
No, they don't. We've written, they haven't been listening.
It's depressing,
Yeah.
But if you spoke
Well, we haven't been
as an
enough
organisation with a loud enough voice, they would.
Yeah.
I
Well,
think we
should
need to
try
know
it.
how, though. I would say, don't
Yeah.
we really? I think
Yeah.
maybe that's the question.
Yeah.
We know kind of what we need to do, but it's
Yeah. Well, I think it's
how we do it.
encouraging. Yeah.
Well, I suppose my advice would be that they're more amenable to positive suggestions rather than complaints. So if you were to come up with what you felt to be the basic standards of care that should be delivered to all children with TOFs, and put your moniker behind that,
Okay.
they'd be hard pressed to resist it, to be honest.
Well, thank you for those words of encouragement. I can see one more hand here. I'm conscious that lunch is at 1 o'clock, and I wanted to do one other thing as well, which is to ask those of you, would it be all right if we ask people to actually write down their name on the back of this sheet of paper, if you would like to participate in this, and then at least we know we've got some interest to start with before we write to every member in the in the TOFS organisation about this. One final question?
It's just, how do we go about establishing TOF as a lifelong chronic condition? Because obviously once we've got that label, we can then get the care starting from naught to 11.
Well, I think anybody who has the condition or who deals with would have to acknowledge it's a lifelong condition. I mean,
Under NHS guidelines, is it like a
I don't know the answer to that, to be honest. No idea.
You see, I think a lot of this could be said for a number of pediatric diseases. I mean, because when people see a successful outcome, i.e. survival, they assume problem solved. And that's when many, I agree with Matthew, I'm sure everyone would agree with this as well, but I mean, I'm surprised by the number of you have been discharged. But that's possibly a reflection of one, an overpressed health service. I'm not excusing, I'm an Irishman, I can say what I like. Health services have worked in 3 in Europe and the United States and here. And 2, why do we keep bringing people back for when we have cancer waiting targets, etc., etc., etc. And that applies for many conditions of pediatric surgery. Gastroesophageal examples, Daft Mediterranean patients share many of the common problems that you folks do, and I think that's how that has happened. But for conditions that carry a threat to life, such as liver failure, things like that, all conditions we treat in pediatric surgery, that's why those sort of children have continued investment through to adulthood. Because people assume that when you've had your esophagus picture sorted, and that's hearing about so many people's stories. I'm really surprised by it. Even though you enjoy good health, because many of you do, and thank God for that. But we have an open policy with our patients, as I'm sure Emma Dawson needs with David Crabb in Scandinavia, that people can phone us, but we would say to you, if you don't mind, we're sorry we're like this, come back and see us in 2 years. So we keep we keep a tab on you until you're going to be transitioned, and then we do that with a very good letter, and that's you're empowered with that letter. That goes to your family doctor and our good networking with some of our adult colleagues.
I think the networking needs to be improved.
Well, that appears to be the case. I mean, I don't know where many of you folk are from, but I find this quite an eye-opener.
Okay. Well, thank you ever so much.